complex, simple CTO lesions or simple CTO case. I have a man, he's hypertensive, 5 years ago, and type 2 diabetes. The first onset angina was 1 year before the coronary angiography, and he was diagnosed as an ischemic heart disease only 1 month before the angiography. He had a positive stress test, and it was positive in the intraventricular wall ischemia, and the coronary angiography was done. We have blood system injection. Second branch is totally occluded, and there is a lesion in the first branch. It's a large vessel. It's a tight lesion, and as you see, there is a related collaterals to the right coronary from the system. Again, there is a filling of the right coronary system from the left system, and so we don't know the onset of this the occlusion of this right coronary, whether or it is a year ago when he starts to complain. Here, the total occlusion of the right coronary artery, proximal total occlusion with, I think, J-score, JCT score +2. There is an ambiguous occlusion because there is a branch at the side of the occlusion, maybe tapered, so maybe 1 over 0. No previous trial and no calcification, and I think it is about 20 millimeters. And there is an intercoronary collaterals from the right to right collaterals, as we see. Again, the right coronary. So the decision was to start PCI of this CTO occlusion, and then as all of us when we start the CTO PCI, there is a dilemma of choice of the tools, whether to start with a simple wire or complex, make it complex. I usually use to make it simple as possible as I can. So I started with H2MS guide wire, and then pilot. I went to pilot, I think 550 wire, and there's a cross of the lesion. There's a bend of the lesion in the lesion, so it may be score 3 because of the bend. And there is no support the guiding here, as you see. When I started to support the wire with the Artemis balloon, the guiding, but I could cross more of the lesion a little bit forward. So I succeed to cross with further balloon support, as we see that it is more distant than the previous picture. And at this time I sought the use of the audio wire, or the use of anchoring wire in this branch, but I tried at this moment. I think in the use of the anchoring wire and another wire to cross, but I tried manipulation and then finally crossed with the support of the 125 balloon, 1 by 12, and then started redilatation, and again flow is resumed. And as we see, that's a long lesion, long total fusion segment, and a larger balloon dilatation was done. Further dilatation, then long 2.75 by 48 science expedition stent, GS stent, started at the origin and the ostium of the RCA, because all of these segments was diseased, and then flaring of the stent, and this is the final result of this CTO RCA lesion. The patient was free of symptoms for about 6 months, and then despite there was a lesion in the circumflex second diagonal, and so I thought that these lesions were responsible for the symptom of the patient, and decided to do coronary angiography again. And as you see that here second diagonal, it's not a small branch, as we see that's a very large area. It's showing the fainting collaterals. It's not small, it's a long artery, but the caliber is small. And the lesion in the OM branch is a 90% lesion, and the surprise that we have any stent restenosis in the right coronary, and I think this segment was pre-dilated during the previous procedure. So I decided to go first with this dilatation and with drug balloon. And I think this is the final result. Then to make it, to close his subject and symptoms, I decided to go to the other vessels affected, other affected vessels. So I started to do the intervention. It's a tortuous vessel, as you see. Then finally crossed with the stent, and in order to avoid putting it in the circumflex, and put it in the proximal segment in the ostium. So adjusted and expanded. So finally, I decided to go to the second diagonal branch, and as we remember that it was 9 months ago occluded, and maybe more than this time. It is at the origin. Some colleagues said that leave it and don't injure the LAD. Again, support with a balloon, Artemis balloon, and I could cross the lesion and did pre-dilatation and resume the flow. So the decision now is whether to do a drug balloon or to put a stent in this long disease segment. We don't have drug balloon available all the time, and because of the expenses, sometimes we use the stent rather than cheaper than the drug balloon. Sometimes. So I did the balloon dilatation, the Artemis balloon, and started stenting of the diagonal branch without LAD compromise, and so this is the final result. In summary, Artemis balloons are now achieve across and successful.
Thank you, Dr. Mahmoud. That's some nice, interesting cases.
Thank you, Jim.
I think it's been a fairly interesting session. Thanks very much to Brosmed. They've been quite regular with these webinars, getting speakers to share their cases and helping us learn from each other. Also meeting some new friends along the way. So we'll wait for some questions to come, and as we move along, questions. And if any of you guys want to add anything, please feel free to go ahead. So there is a question here: what's your regular use atmosphere for Apollo? Well, it depends on what my inflation device allows me to go. So if I can go higher, I'll go as high as I need to and can.
With me,
any other questions from the experts?
Yeah.
Yeah.
So I just want to say that Brosmed is on a good track. I have used a lot of balloons from a lot of companies, and the problem, we have also some reimbursement issues and cost problems in our country. So the one affordable best balloon in Turkey is now that from Apollo. Of course, I have different channels. I can also have a lot of different balloons, but the 1O balloon, the CT balloon is fascinating. And if something happens, I have also used the regular balloons, balloon uncrossable CTOs and something like that, and septal pre-dilations, and Artemis in that sense helped me a lot. And if Artemis does not go, I have not seen any other go as well. So I just want to say, keep doing the good work with these balloons. And the NC wedge, about the NC wedge, there should be a way to have an FDA approval for the NC wedge balloon that we use, that is designed for peripheral intervention. Because if we can use this 3-wire balloon over the balloon with 3 wires in the coronary, I think we will change the game a little bit more to another frontier. That's my opinion. That's how I see it. But another thing is, we should have the right tools in our cath lab. If we should have the right tools, if we don't have a scoring balloon, if we don't have a rota, if we don't have a good NC balloon, then I think it is the best for the patient to refer to go problems that we have. That's not a good way, because you end up with a lot of complication. My perforation rate almost went to 0 when I began to use rotablators, scoring balloons, cutting balloons, and prepare the lesion as it should be. My perforation rate downs almost to 0. I had a lot of complications in the past, and the reason was the cost issues. You have a balloon and you want a balloon that has a bad profile. You cannot cross. You push it, you try anchoring, you try different solutions, and then you go to high pressures, and then you end up with complications and perforations. So you have at least prepare the lesion in a proper way if you do with calcification and complex lesions. If you don't have that expertise, and if you don't have the necessary means in your cath lab, I think one should refer the patient to a surgery if it's an LAD. That's what I have to say.
That's a very interesting take, Shevket. I absolutely agree with you. You know, sometimes when you're trying to cut costs is when you really run into trouble.
Yes.
Saying I've used a NSD scoring element when really high pressures, ruptured the left main, you know, have to put a covered stent in the left main. Yeah, so that can be quite scary, you know, when you could have got away with the initial arthrectomy or now with the shockwave balloon and whatnot. Yeah. So, Dr. Mahmood, would you guys like to add anything on the session? Or?
Yeah, it was nice talking to you, and I kind of just add one tip, like when you're doing a pre-dilatation, I use mostly just for getting access, I get at times, and then for proper doing it, you also do the NC balloon for pre-dilatation. I take for the 3 mm vessel, I take a 2.5 NC, I go up to 24, just to break it, whatever is there. So then only you can get a 3 mm stent properly deployed, and then a 3 mm post-dilatation. So suggestion is like pre-dilatation with a non-compliant balloon is definitely useful, especially you can avoid. If that's not expanding, then you know there's something wrong, and then you go for the next level of preparation, cutting balloon, scoring balloon, or IVL, whatever. So I just like to break the whatever the tissue, tough tissue before you put a stent in, rather than settling later. There was one question about how much atmosphere you go with the Apollo. Like you said, like 24, 26, 28 till the end, no problem. But I know almost never use non-NC balloon for 12, 14. That's you don't need. There's no point near 12, 14. If you're using NC balloon, you at least you go for 20 plus. There's no point using a non-compliant balloon less than 20. Of course, you have respiratory size of the artery. Can oversize it.
Thanks, Dr. Saravanan. That's an interesting take. I think a few years ago, I can't remember, it's like maybe 6 years or 7 years ago, I read a paper that mentioned that the optimal atmosphere for an NC balloon is 21 atmospheres. I'm not sure if anybody remembers this paper or not, but it's been quite a while. I can't remember exactly what the paper was. Yeah, so you're absolutely right. If you're going to take NC, you got to go high pressures.
Yes. Dr. Mahmood, do you have any suggestion or a supplement? Hello, Dr. Mahmood. Yeah. Okay, now we can hear you.
Because we in the last few minutes we have I haven't internet interruption, so I'm sorry. Are you going to ask? Would you like to ask anything? Do you have any question? You hear me?
Yes, yes, we can hear you. Yes, and no more question from the audience. Yes, and okay. So thank you. Thanks for all the experts, and thank you for today's wonderful presentation and comments. It's very helpful to us with many insights and tricks on the complex PCI. And thank you for all your experience and the trust and support for Brosmed. It was a great honor, and we will keep going to bring our products for excellence. And dear audience, and for more product information, you can search Brosmed website or contact us via email sales@brosmed.com.
So I have another suggestion, if I'm allowed to say. So I would like to, of course, we didn't have shared any cases with intravascular imaging. So intravascular imaging is also an essential part in my complex procedures. And sometimes I see left veins like 6O. Okay, so there is only, I think, 6O balloons from SIMPAS, and there are 6O balloons from, I think, from Boston. Yeah. And I let SIMPAS make the balloons special for me. They make a special series 6O balloons. Sometimes you need 6O balloons in left veins. If you have intravascular imaging, and in intravascular imaging, I do all my left vein cases with IVUS. So I don't do any left vein cases without IVUS anymore. It was in the past. And it changed my maneuvers, it changed my completely after using IVUS. So my other suggestion is, balloons, it would be awesome.
Okay.
That's my other suggestion.
Okay.
6O balloons.
Okay. Thank you for the new marketing input. Yeah, I will transfer to our R&D.
So as Jaja has said, he has not 30mm balloon. So 30mm balloon is a good marketing direction. So we need it if you do complex, and it's the same. We need also 6O balloons. So that's it.
Okay, thank you. Yeah, Brosmed will also try our best to meet the clinical and the physician's needs.
So we have 10 minutes left. I think that's the reason why I am talking so much. If anyone want to come in and have suggestions and have any comments, they are welcome. Jaja, I am not hijacking your moderator position. I'm just trying to.
This is a very casual chat among friends, you know.
Yeah. So we have time.
Carry on this.
And I see Michelle is struggling and want us to say something. I have a lot to say. I can also tell you some jokes if we have time, so no problem.
Okay. Okay. Thank you. Thank you. And I will meeting with our leaders and to discuss with you some new products. Okay. Thank you. Thank you all the experts, and thank you for the audience. Looking forward to see you next time. Okay. Bye-bye.
Okay. So,
bye-bye.
Thanks, everyone. See you guys. Bye. Have a good weekend.
Alveo HP has the world's smallest balloon diameter at 0.75 millimeters and has an ultra-low tip profile of 0.0156 inches. Low crossing profile of 0.49 millimeters. Easy crossing of complex lesions and CTOs. The robust RBP of 20 atmospheres, Alveo is ideal for severely calcified lesions. What is POT? The proximal optimization technique, POT, has been proposed as a strategy to improve the results of stent scaffolding of bifurcation lesions. It is a straightforward technique whereby a short, appropriately sized balloon is inflated in the main vessel just proximal to the carina. The POT PTCA balloon dilatation catheter is indicated for both the proximal and distal optimization technique. The proximal segment of the stent can be evenly expanded to improve stent strut apposition. The extra short balloon shoulders reduce longitudinal balloon growth, minimizing the potential for vessel trauma outside the treatment area. Provides accurate post-dilatation stenting and reduces vessel wall injury. Rated burst pressure up to 22 atmospheres for stent expansion and apposition without any dog bone effect. Wedge NC, indicated for osteolesions, bifurcation lesions, long diffused lesions, in-stent restenosis. With one fixed nitinol wire on top of the balloon surface, Wedge NC provides exact scoring and avoids twisted wires or interference with the stent. Wedge NC has the same easy handling as a conventional PCI balloon catheter, but with additional scoring effect. The fixed nitinol wire provides more concentration and less slippage on the vascular wall to effectively modify fibrous and calcified plaque. After complete dilatation with the Wedge NC, the well-prepared vessel lumen ensures that a drug-eluting balloon or stent can be accurately positioned.
Crossing a tight lesion despite it being used, despite it being weak. So the reading is actually pretty good. So again, for the LED, just put a drug coated balloon, a 2530, and we achieve very good immediate results. Usually, you know, after a drug coated balloon like this, I tend to wait 5-10 minutes to see if there's a acute closure, and that did not happen. So I'm actually going to bring this young boy back in about 6 months and see if there needs more definitive treatment to see if his vessels have grown, and I'll take it from there. All right, so third case, this is a much elder gentleman, a 77-year-old diabetic hypertensive, had a previous stent in the LED 20 years ago, presented with a non-ST elevation MI and ejection fraction of about 45%. This is an angiogram, large left main, large cervix disease, very large right, you know, some sort of diffuse disease, but nothing critical. So I decided not to treat the right coronary because obviously the symptoms were coming from the LAD. So we went in, managed to cross a wire into the diagonal, balloon the diagonal with a semi-compliant, and then we decided to take a cutting balloon initially for the elevator descending, but as you can see, it did not really open up very well. Even though thereafter we decided to take a scoring balloon and went up high pressures, and that did the trick. It opened up quite well. But we kept losing that diagonal. You know, we use a semi-compliant, comes back for a while. So at this juncture, actually, we were thinking that should we put a drug coated balloon, because the old stent, should we just stand across it? There was quite a lot of recoil. Even I was shocked that. So we said, you know, I'll just put in another DS. We put a 3.528, and we had a lot of trouble trying to rewire the diagonal after that. So what we thought that so we took a pot balloon. So we that diagonal, accidentally I should put the diagonal part. And then pot to finish up. We thought the results were fairly decent, and patient has been increased since. So the pot balloon is very interesting. I kind of like it, to be very honest, because I think it's better pot. It's not much. The last case came in with so you can appreciate it's got a left main, some calcification in the left main, very large flanks, tight proximal osteo LED, and if you can appreciate the calcium down there, some disease in the right coronary in the mid segment. So this gentleman from the word go decided to do some atherectomy. So I actually proceeded to do a orbital atherectomy. I felt that that would give me the best clearance. But you'll be actually surprised that the ring calcium, which was not at the ostium, rather it was about the visible calcium. So the 360 calcium actually further down, in fact, rather than at the osteoproximal. So after atherectomy, you can see the wedge NC opened up very nicely, 2.5, but with all my calcified lesions, especially vessels that I know are large, I'm pretty afraid that it would not open up fully. So I always prepare them to my heart's content. So then I took another wedge, a 3.0 wedge, and I was quite happy that I knew it to open. So on IVUS is actually a very large vessel, 3.5, 4.5, and a 5.0 left. So initially we put in the 3.5, the 3DS, opposed to 4 Apollo. And then this is the immediate results. And this is a 5.0 the circumference post dilated the rest of the sand with the same balloon. And really beautiful results. And I did not have to do much more after that. So I have to say if there is one complaint I have upon is that it takes a little while to deflate if any of the other have experience with the pot balloon. It takes a little time to deflate, so you have to be patient after deflating the balloon. Don't just try to yank it out from the catheter. We had run into some problems with to be honest. That's probably still really bad if it's not making it. Message for me from my talk. Treating complex coronary lesions, to be very honest, are simplified the tools like balloon and has been around for a long time, and now and obviously not all lesions are the same. So, different tools are necessary at the discretion and experience of the operator, and of course it's good to be familiar with a few, expert with a few, but it's important to know all that is available as to not limit the option of the patient. So I thank you, and as we go along, feel free to shout out questions. If any now, I can take them. If not, if there are no questions now, what I will do is, as we go along, all of us can share to answer the questions. So I will not hold up much time. We don't really go to that unless we cannot open up the vessel. So it's semi-compliant, non-compliant, and then we have so what happened was, this is a personal experience of mine. Somewhere towards the end of my training, I sort of shifted So what happened is I wanted to DCB most lesions, and I automatically shifted to a scoring balloon from the use a semi-compliant balloon to open up. And then I actually score almost all my lesions, so that I feel that the version is really good with a scoring balloon. It doesn't matter what scoring balloon you have. And it's a good opportunity to apply drug balloon if the immediate pre-application results are good with the usual disturbances for less than. Having said that, balloons are not exactly cheap, right? So if you're in a lab where you're not at luxury place, so most people use semi-compliant balloons. I know some operators around the region who only use non-compliant balloons. They don't really use very much semi-compliant balloons. So it's based on experience and of course local.
What's the advantage to use a pulse balloon compared with common balloon?
So the balloon does not have a shoulder per se. It doesn't wing out, right? So there's not much overhang. So it's extremely short shoulder, right? So you get to you actually do a proper pot in that sense, because the pressure is applied right at the area or the origin of the branch that you want. So the main advantage is the extremely short shoulder. So I've been using a lot of it. Presented fairly recently. The issue on stand after using the pot, how you feel it's like how when you draw and what pot should look like. It looks exactly like that, because the left end was huge. It's a 3, I'm not sure 3, but it opened up really nicely to the so I regret that I did not put up that picture. You know, it's a typical picture that when you want to show a pot, that's how you draw it. So that's how the pot balloon actually helps to me. The short shoulder is really, I got quite good experience with it so far. Yeah.
Thank you so much.
I think we will continue to take questions to go along. Without further ado, it takes me great pleasure to invite Dr. Shevket. He's going to talk to us about Artemis and Apollo, the balloon and complex coordination.
Close and open together. So someone can guide me. It would be easier for me to share my screen again. So just help me. So I'm again. Share.
Yeah.
Okay, I'm now on. So let's go to the presentation. Okay. Okay. Before I begin my speech, I would like to thank Brosmed for putting me into this. The that means I have 8 years of experience with this. For the last 3 years, I used to be one of the 5 operators with the most days in the Eurocentral Club. This is this year's ranking so far, but the year is not over yet. I think I should be one of those who get credit for having Artemis on the EuroCTO registry form, as Artemis is the only balloon I use in CTOs. Why Artemis in CTO? I will mention it later during my talk. When we talk about complex coronary intervention, we mean left main bifurcation, CTO, calcified coronary artery intervention, centric stenosis, but for me, just only CTO, as it comprises all of them. This is a 52 years old male patient with stable angina. Radial operator, complex cases, procedures where the radial approach CTO and left brain procedures, definitely branch, bifurcation procedures, mostly 6 French. With 6 French, you need high quality balloons. So Artemis and Apollo are compatible with 6 French if kissing balloon is needed. This is a bifurcation lesion. This was a culotte procedure. I have to show you first. This is like this. Okay, you have seen the previous slide. So 2 by 20 meter Artemis balloon first UM, then CX. We so first we solve the dissection with the stand towards the OM branch. We did a part with 3 by 18 millimeter Apollo and then rewired the OM again, and the CX and the same balloon that we used previously could cross the stented area towards the CX, as you can see on the right panel here. So thanks to the low profile features of the Artemis, we could cross that stented area. Standing towards the CX, and then you can see the wire exchange again to the OM. One can see how beautifully 2 Apollo 2.5 by 15 millimeter balloons were positioned easily through a 6 French guiding catheter. Pot again, and on the right panel you can see the end result of this culotte procedure. Here, this is a bifurcation lesion with a reverse angle of the diagonal. The takeoff is retroflex and more than 120 degree. Sasuke double lumen in place, filter FC, and a hairpin maneuver in action here in this. Diagonal. Once you crossed it, with the wire, here comes the 2 by 20 millimeter Artemis balloon. Lesion predilation, the stent was crossable only with the anchor balloon in the LAD. 2 by 10 millimeter Artemis was placed in front of the diagonal stent. This was the DT crush procedure stent, which was crushed with this balloon after stent deployment. Dividing the diagonal again, 2.2 by 20 millimeter balloon couldn't cross even with the anchor balloon, as you can see on the right panel. If you are doing complex cases, you should also be prepared for using CTO balloons. Here comes the 1.5 by 15 millimeter Artemis CTO balloon. It crossed with the help of the anchor balloon, and here you can see after the dilation and then the first kissing with 2 Artemis balloons. Stent deployment and then pot with Apollo 3 by 10 millimeter balloon. Here, dividing the diagonal again, second kissing balloon, And this was a very approach, of course, with 6 French guiding catheter. And pot with 3 by 10 millimeter Apollo, and here comes the end result. So, in complex cases, you need sometimes CTO balloons in terms of recrossing the struts of the stent before kissing. In that terms, at least for me, Artemis has proved itself to be a good one. Artemis balloon has a special space in my CTO procedures because of its features. This is an ambiguous cap, RCA CTO cap we got through the septals here. This was a turnpike LP, and this was a scion wire, I think. And the microcatheter couldn't cross. The turnpike LP is a low profile microcatheter, but it couldn't cross. So we used a 1.520 millimeter Artemis balloon, and we ballooned all the resistant parts of the septals. The microcatheter follows the wire after septal predilation. Retrograde wire in the guiding catheter on the left panel. I'm just waiting for video to move. Yeah, now it's coming, and the turnpike LP in the RC, and now the wire comes and goes into the guiding catheter easily. Micro in the guiding catheter, here comes the RG3. After ballooning and stenting, one can see the final result on the right panel. By being able to predilate the septal with this Artemis balloon, it saved me a microcatheter, which otherwise I had to change to another one, to a Carnaval, to a fine cross, or a more braided one rather than a torqueable one. So it saved me money. It saved me money in that. It's important. So here comes another CTO, and this is an RCA CTO, ambiguous cap. We have interventional collaterals. Thanks, it's a luck to have interventional collaterals. And this was a case with a previous failure. The JCTO score is 3. In CTOs, if you want to succeed with less hassle, you should begin with a proper setup. A side branch anchoring balloon. A side branch anchoring balloon is mostly crucial for strong backup, which facilitates advancement. So the balloon quality is of high importance in crossing the tiny, most tortuous side branch for a functioning anchor. The left EL sits safe in the coronary thanks to the Artemis 2 by 15 millimeter side branch anchor. Here one can see the tip injection. Here one can see the tip injection and of septals to verify that we are in the right track. Scion wire crosses the septal. Here you can see. And after some surfing maneuvers, we are through with this scion wire here. I'm just waiting to cross the septal here, and then I will go further. And here the scion wire anchoring to the PL branch of the distal RCA, contrast injection, and from the micro give us an understanding of the distal cap anatomy. Here it will come. This is the distal tip injection to understand the anatomy. And we applied the contemporary reverse cut with a 2.5 millimeter Artemis balloon. First, we wanted to touch the balloon with the wire, but luckily it went into the antegrade guiding catheter, as you can see here on both panels. Here, we trapped the wire and the shaft of the anchoring balloon. The micro went into the guiding catheter. As a general rule, one should not trap the anchoring balloon, as you can compress the lumen and hinder the deflation of the balloon. This kind of scenery has never happened to me with the Artemis balloon. Of course, it doesn't mean it will not. So the Pilot 200 was exchanged with R350 after ballooning, the empty micro was trapped to prevent a comeback into the RCA, as you can see here in the left panel. And Artemis 2 by 30 millimeter balloon for predilation. Once you cross with a micro, you don't need a CTO balloon anymore. 30 millimeter length balloon covers the whole lesion, prevents further dissection, shortens the ballooning procedure, and radiation time. 30 millimeter length Artemis balloons are my first choice once I crossed with a microcatheter. So here comes the further ballooning, checking for any collateral damage here on the right panel, stenting, and here comes the end result. And here comes it again from a different view. In my routine practice, in my routine proctoring practice, I always ask for a 2 by 30 millimeter long balloons from Artemis. As I am in a foreign cath lab, and there are already some adjustments I have to make, which means time loss and more radiation exposure and a little bit more frustration. This is, therefore I need long balloons, definitely long balloons in CTO procedures. This is an RCA CTO with an ambiguous cap. We intended to use the epicardial collateral here on the left panel, and corsary pre-access and serum wire cross the epicardial collateral. In this case, the retrograde anatomy is totally because of the previous cabbage operation. We are nowhere land with the micro here, and we didn't integrate this section re-entry integrately and draw the guide liner as far as we can in the distal part of the RCA. First, we tried a just marker approach, but we had to change immediately to a reverse card procedure, guide liner assisted reverse card procedure. And here you can see the gladius on the left panel going nicely into the guide liner. Retro microcatheter and RG3 is in the guiding catheter, in the guide liner. You see wire externalization with this long 2 by 30 millimeter Artemis balloon, and here comes the ballooning on the left panel. Further ballooning, and after stenting, we are doing further ballooning, and after stenting, we lost the PI as one. So we regained the PL with the help of a fine dual lumen microcatheter, kissing balloon with 2 long Artemis 2 by 30 millimeter balloon, and here is the end result. So in summary, I'm going to summarize what I have talked. Non-compliant Apollo balloon is very effective in left main and bifurcation lesions, as it is low profile, efficient, reusable, fits in 6 French guiding catheter when kissing is needed. And the Artemis balloon is fascinating in CTO procedures with its different features. You can easily predilate a septal or predilate a micro uncrossable CTO with the 1.0 balloon. The 30 millimeter long feature gives you gain in time, contrast, and radiation exposure after crossing the CTO with a microcatheter. And that's all I am going to say, and thank you all for your attention.
Thanks, Dr. Şevket. Wow, there's some very nice cases in the use of Artemis, long Artemis balloons. Unfortunately, I don't have any semi-compliance that are more than 20 mm. That would be really nice, to be honest with you, to have some long semi-compliant balloons. Okay, there are a few questions. I think maybe I'll just throw these questions to you, Dr. Şevket. What's the percentage for bifurcation lesion in complex PCI?
What's the percentage of
Maybe you can answer from your experience. What's the percentage of bifurcation techniques you use in your complex PCIs?
That's the question I should be answering on, because I am not doing a regular angiography. I am just doing complex cases. I'm doing CTOs, left vein, and if you, in my experience, about 20 to 25 persons in CTO, I have to deal with the bifurcation after the CTO procedure. It can be a bifurcation lesion before the CTO. Also, it can be within the lesion. It can be also in a distal bifurcation manner. But the percentage is about 25 to 30% in CTO patients, and in left main patients, if you have a left main, if you have an ostial left main, the percentage is very low, and if you have a distal left main, you have to do always bifurcation procedure. So I can just answer it for CTO procedures, 25 to 30%.
Thanks. I mean, I think that's not very far from my experience as well. Another question for pod technique: do you think NC balloon is better or a semi-compliant? I mean, a pod is basically post dilatation. So I think most of us here will go with a non-compliant balloon rather than a semi-compliant balloon.
Yeah.
Do you disagree? Yeah. So if it's a post dilatation, definitely we'll go with a non-compliant.
Yeah. So we want to have a good expansion of the stent to re-enter the side branch. So we have to be sure that we have a proper expansion and good niche to enter the side branch. So for that reason, non-compliant balloons are almost essential in these circumstances. I think it's my opinion.
Absolutely agree. Absolutely agree. So Michelle, shall we move on? Thanks, Mr. Şevket. Just stay on, and we can all discuss together later on.
Yeah, there's no more question from the audience, and thank you so much for the Şevket. Thank you. And now we will invite. We will start our third topic from Dr. Saranam. The topic is complex PCI with a VO. And Dr. Saranam is the member of BCS, EAPCI, and the CSI. Welcome.
Can you hear me, Razak?
Yeah, Dr. Saranam, we can hear you quite clearly.
Thank you for the opportunity. And I'm going to show you a couple of cases where I found the alveolar balloon was very useful. And something we do see very often. First case is 82-year-old man, very active fellow. Came initial drop was negative. He was having some intermittent chest pain with elevation. So he was taken for angiogram. That's his angiogram. He's got a disease in calcified disease in LAD and circumflex. Good calcium there, and definitely good targets for grafting for the mid vessel, but we're not doing that anyway. So that's the LAD. So this is where the culprit lesion was. It's a right coronary artery. Tight lesion, but there was TIMI3 flow. Discussed that's a tight mid vessel lesion. A lot of calcium in it. So discussed grafts, the PCI, and patient family would like to have more medical therapy, and patient didn't want to go for surgery or PCI. So he was given maximum medication, almost everything was given. And he was having intermittent chest pain in the ward with ST elevation inferiorly. And he was kind of, I was having some evening meeting, but he was having pain. So, okay, we just took him for a emergency PCI for right coronary artery, which we think is a culprit. So the 6 French radial JR4 run-through wire was taken. Quite difficult wiring. The flow was there, but initially I was suspicious whether there was some thrombus in addition to the calcium. So tried to wire, it was run through wire, but managed to get that. Couldn't get any, took a normal 2 mm balloon and didn't go, so took a 1.5 Ryuri balloon. The guide going back. Here I'm not keen to do a complex PCI, I just want to get a better flow and get away that evening. So there came Alvio to help me. So Alvio managed to get in with that poor support to get there, did dilatation 0.75 and atmosphere about 22 atmosphere. You can't see it because it's a very small balloon. And that gave some kind of hope. And then I tried the balloon again, it was not going, so decided to stop because it was going to be complex. The flow was okay, and was sent back to the ward. It was settled initially, and then we decided to go for a complex PCI. So this time we took a 7 French AL guide and exchanged the rotor wire with a Corsair. And then you can see there is no, couldn't get rotor wire distal to this. Managed to burr initially to the path, and then we have to about with the burring, push the rotor wire further, and we got a lot of backup support needed there. And but 4 minutes back was 1.5 burr, and then we got this result. But anyway, got it there. High pressure bump dilatation, and that's the end result. This was good, and then proceeded to left. Initially tried to do IVUS first to see whether they can need IVL directly, but IVUS could not go, so I went to the rotor for LED. So rotor floppy wire was directly taken, and then 1.25 mm burr was taken. The 1.2 burr was taken because I was planning to do IVL because a lot of calcium and very thick plate of calcium, so we decided to go with IVL shockwave balloon. So that's the shockwave balloon. First pulse didn't open much, and second pulse it cracked, and did some more dilatation, and then stent was placed, and post-dilatation was done. The circumflex okay, but that was still a lot of calcium. Case I'll go through. This case is a reputable lady who had a stent done in 2016 by myself, and that time she had this time she came with a chest pain, acid depression, rapidly, and dysfunction. So that's the lesion, and got a thick sheet of calcium, that's a culprit lesion. My old stent, actually it was protruding in the ostium, not bad for 8-year-old stent, but unfortunately you can see some struts across the circumflex ostium and there's a lesion there. So I'm spreading a lot of difficulty in this one. I just don't want to do the ostial side, I just want to get a stent to the mid vessel, that's the intention. So the old LED stent was good. I was impressed as well. And that's the angle. You could see the struts kind of crossing across because it was ostial LED, so struts invariably came to the left line. That's right coronary. So I kind of tried, wiring was not an issue because the wire went in very easily. But I could get a difficulty just there itself because I could not even come there. It's just the angle. It was a SPB 3.5 backup guide catheter, and that's a small balloon upload, could not go in. That's the difficulty I was having there. So I used a body wire and tried, didn't work. So that's a body wire, and tried the same balloon. I couldn't get it. This is I got a guide extension after as well. I got a guide extension and a little bit of support. Still couldn't get across. Next was a used a 1.5 IUV, and that went across the struts and was able to go to the lesion. I was able to go at 10 atmosphere. The problem with the soft balloon is you go higher pressure, they burst. So got in atmosphere, and then luckily I had alveo on the shelf, and this is a 210 alveo, and that kind of went reasonably easily to the struts with an angulation. And it was pushed in that place. And then at 24 months, that's another advantage. I could go with a high pressure without bursting the balloon. There was calcium there. It gave a reasonable lumen area. Then that's a lot of support of guideliner and the double body and everything. So I tried again before taking a stent. I just want to see whether I could get the buoyancy up again, and I could not get it again. So that's a very short balloon, and it just couldn't go. So there I decided to stop because I had my intention of clearing the lumen was good, and this is a more complex lesion, and if I have to stent, I'm going to extend from the ostium to here, and I cannot get a stent because I don't want to take a stent through the stent struts, then I may stent. So I was happy, and she was stable, and she was discharged with no issues. And if she comes back, then I have to think about what I'm going to do with her. So that's the final result of this. And so just to brief about alveo, it's a very nice balloon, very nice crossing profile, very easy to cross. That's not a problem because we've got a lot of balloon with that. But one main thing is you can go to very high pressure dilatation. Here you can go up to 28. I used up 26. Nothing happened so far. So it's just a good balloon to have in your shelf. And thank you.
Yes. Thank you, Dr. Saranan. Yeah, and the alveo actually is now the smallest balloon with the 0.75 ml in the world now. Yes, and thank you and for your appreciation. And Doctors Jariat and Shevket, do you have any question or idea need to exchange?
So we have some alveo on our shelf. I have to be honest, it's not my go-to CTO balloon, but we've had some experience with the 0.75, rescuing us in time of need. So it's a pretty decent balloon. You can go high pressures with it. So my experience is sort of limited with the LVOHP, I have to say. Yeah.
It's a good balloon because the case, especially the second one, where I had to go through struts and need high pressure to break the calcium, and it was perfectly suited there. So, different indication. Just it doesn't break with higher pressure. That's the advantage, because otherwise, anyway, we're not going to stop at a 0.75. We're going to upgrade. So, that's it.
Dr. Şevket, you're still muted. Sorry.
Yeah.
So I would like to say something to Michelle. Michelle, you should some of your HP balloons, because it sounds very effective. I have used a lot of balloons. Okay, I am using the angioscope a lot. I am using the Scolaflex from Orbis Nice, and I have been using the NC wedge a lot, and I have been using the Flexstone, the Wolverine balloon, and I have been using them if needed. So what I want to say about the wedge balloon is the wedge balloon has a lower profile if we compare it with the other scoring balloons. And there are some cases I was not able to go through the lesion with the other scoring balloons, and the NC wedge balloon went nicely. Has just one scoring element, which is one wire over the balloon, and I would have to use the balloon, the NC wedge balloon, with 3 wires, but this is only dedicated for peripheral intervention. So I would be very interested in using it. I know it's off-label, but in the coronary, I would like to see the effect of that balloon. The angioscope, as you know, has a spiral helical convoluted design, and it seems to me that has a better scoring effect, but the profile is not as good as the NC wedge balloon. So my interest would be in to use the 3-wire NC wedge balloon and see the effect in calcified lesions. And with the LVOHP balloon, it should be in my toolkit. It should be in my device armamentarium, because there are a lot of CTOs I cannot cross with regular balloons. Even in some cases, 1mm Artemis balloon, for me, it is one of the best. I used also the Sapphire balloons, and it couldn't cross, and I crossed with 1.0 balloon. And there were also cases that I couldn't cross with 1.0mm balloon. In that cases, I use a Turnus or a Turnpike Gold, which is very expensive. In that case, the LVOHP balloon could be a good solution. So I have to try it. Michelle, you should send me one.
Okay.
That's my comments.
Okay, sample are on the way. Okay, I will arrange after meeting. Yeah, and thank you for giving us the new direction for our future products. And yes, thank you a lot. Okay. And
share.
Okay. And now let's welcome Dr. Mahmoud from Egypt to give us the final speech. Welcome.
Yeah, you're welcome. Thank you for inviting me to join you in this meeting. And thank you for all. Thank you for. I enjoyed the presentation of cases. Really